Welcome to the EGVRS tour around the retina world in 30 days. In this tour, we will get to meet the stars of vitreoretinal surgery around the world. We will get to know more about their personal life, their success stories, their dreams, and even more. For 30 days, we will roam Mother Earth, exploring the retina world around us, communicating and learning from each other, not only about the retina and vitreoretinal surgery, but also about their wisdom in life. So our stop today will be in Africa, and we shall land in Kigali, Rwanda, to meet Dr. Shiko Matengi, the retina star in sub-Saharan Africa, and the powerhouse behind the success of COEXA, the body which has enriched the practice of ophthalmology in sub-Saharan Africa in the last decade. I have known her as a very talented and insightful moderator of the retina sessions in the COEXA meetings, and a very dedicated and passionate doctor. Dr. Shiko Matengi is the director of Rwanda International Institute of Ophthalmology in Kigali, medical advisor for Africa for Orbis International, board member, Ophthalmology Foundation, and a medical retina specialist of renowned capabilities. Welcome, Shiko.
Thank you so much, Professor Suleiman. It's a pleasure to be with you. You're very generous in your introduction.
Well, thank you for accepting to join us. It's a real pleasure. And I really miss you. Haven't seen each other for quite some time now.
Yes, because we haven't had COEXA for a while because of COVID, but for sure you will be there at the next one.
Yeah, we hope so. So let's talk about your personal, some of your personal life. I mean, where did you go to school?
Thank you. So I did most of my basic education in Kenya. I actually started school. My father had to lie about my age for me to start school because he wanted me to start at the age of 4.5, and you had to be 6 to start. So he kind of had to fiddle that and allow me to start school early. But I did my everything up to high school in Kenya. I went to medical school in Nairobi, and I also did my ophthalmology training in Nairobi. I have also done additional training, mainly in London. I did a master's in public health ophthalmology in London, and also my PhD out of the London School of Hygiene and Tropical Medicine.
Oh, so you've been around Africa, London, but I mean, was your wish always to be an ophthalmologist? And how did you end up as a retina specialist?
I was never sure I wanted to be a doctor. I was very confused as a high school student. When I did interesting history, I wanted to be a lawyer. When I did interesting physics, I wanted to be an engineer. And it's really my teachers who decided that I should go to medical school. It was kind of automatic in those days. If you did well in school, you went to medicine. So they put me into medical school. I have never regretted their choice. I really do enjoy being a doctor. I went into ophthalmology not by design. I remember after you have to do 2 years of a general practitioner in Kenya before you go and specialize. And I took time off to go and get married. And at that time, I worked in this very nice private wing of the government hospital. And I left my friend to kind of hold brief while I was getting married. And when I came back, she would not move. And I just didn't want to fight with her. So I went to the head of the hospital and said, what do I do? And he said, you've done enough, go to the eye unit, nothing happens there. And so I was posted to the eye unit as a general practitioner. And my first day there was during a busy cataract surgical day. And I have never been so shocked in my life because there were all these old people coming in blind, and the next day they could all see. And it was something I had not been exposed to as a general practitioner. And that really, had an impression on me. But the other big reason I went into ophthalmology was I couldn't bear loss and suffering. So I got really attached to patients, and every time somebody was really sick, I was sick. Every time my child died, I cried for days. So I realized in the eye clinic, people didn't die. And I thought, this is a good, this is a good choice. And finally, it's really hard to get government sponsorship for postgraduate in Kenya. It's really easy for ophthalmology. The exam is very easy because nobody wants to go there. And at that stage, I just felt, I don't want to struggle, I'll go for the easy one. And that's really how I ended up in ophthalmology.
It's really strange because, I mean, ophthalmology everywhere is a cutthroat specialty. It's really a cutthroat specialty. So you had the easy way. Oh, okay. So we'll send you students who really want to go into ophthalmology if the way is so easy in Rwanda. So, but how did you end up as a retina specialist?
Yeah, so I told you I went to school in London. So my first project for my master's was a really weird project. I did this study in a prison, in the main prison, and I was looking at vitamin A deficiency. And I did that because I used to get these people with melting corneas from the prison. And I had never seen a child with xerophthalmia, but I was seeing adults with xerophthalmia. And it was a really difficult project, but I wanted to do it because I was curious about my own patients. I therefore did it really, really well. And as a result of that, got a scholarship immediately to go on to PhD. And the school wanted me to do the same project. I really had enough of prisons. And I said, I don't want to do the same thing. So I was very curious about retina also, because in Kenya and a lot of countries in Africa, we were not really exposed to the retina. And yet, as an ophthalmologist, I was the senior doctor. My mid-level workers could deal with most cases, and all the cases that they ended up sending to me were retina. And I could see the retina, I could describe what I could see, but I didn't know what it was or what to do about it. So I thought my PhD should be in retina, because I felt that what we were being told about retina not being a big problem in Africa was not true. So my PhD project was to look at, it was one of the largest studies done on the continent. I looked at 5,000 people, it was population-based, and basically looked at retinas, imaged them, sent images to the reading center in London at Moorfields, and was interested in diabetic retinopathy, age-related macular degeneration, but also the discs, also for glaucoma. And after that project, I just thought there is so much to do in retina. I've done this epidemiological study. Now I better learn how to treat these things. So I kind of felt I was not complete just with that PhD. I wanted to now follow the clinical aspect of it. And I therefore went to India and did a medical retina fellowship.
Okay, so this actually gets us to a very important point.
Yeah.
I mean, how is the ophthalmology practice in Rwanda?
So Rwanda is a small country, and everything is small, even the number of doctors. And when you have few doctors, you also have very few ophthalmologists. So at the moment, we've just received new ophthalmologists, which brings us to the grand total of 16 ophthalmologists in the country.
Wow, 16,
16.
Wow.
And of those 12 are in the capital city, Kigali.
Oh.
Yeah, so there is a huge shortage of ophthalmologists out there, which is why I run the Rwanda International Institute of Ophthalmology. It's actually a private ophthalmology residency program. And I just felt compelled to do that because out of concern for the quality of training we have, but also I felt that for us to increase the numbers in Rwanda, we needed to train people in the country. All 16 of us are trained in other countries.
Yeah. So let's go to the COEXA. I know that you're one of the actually the founders and a powerhouse for the COEXA. So how did the COEXA actually affect the ophthalmology practice in sub-Saharan Africa?
So COEXA was, put together as we brought together ophthalmology societies from different East African countries. And we then moved it to create a college. And the aim of the college was really to standardize training, because a review that was done about 10 years ago showed that the standards of ophthalmology training were really different, say between Kenya and Uganda, Uganda and Tanzania. There were all sorts of things being called ophthalmology. And the aim of the college was to create standards and then support the training institutions to meet those standards. So COEXA concentrates a lot on curriculum development, accreditation of institutions, a standardizing exam for all ophthalmologists in the region. And it's really done a lot in terms of improving standards of training in different countries, because based on what COEXA finds, we can mobilize resources to support institutions that are struggling.
Great. So a short note about your dreams in the future and for what you really dream of accomplishing in the future.
So I would like, this year, I think I will graduate my first 4 residents from my institution after 4 years of training. I'm really looking forward to that. I currently have 14 residents in training, and I haven't graduated any batch yet. So I'm really looking forward to that, because I think I think I've trained them very well. So I think there will be a good batch of new ophthalmologists, and it's another 25% number increase in Rwanda.
Excellent.
Yes. So training and development of other personnel is a priority for me. But I hope also to kind of slow down a bit on the clinical work, because now I'm kind of juggling all those things, and focus more on research.
Well, thank you very much for this insight into what you're accomplishing, which is something really admirable. And I do understand the difficulties you're facing and the challenges. And I really applaud you for what you're doing. I've seen that myself during the last meetings. And now we take a pause and we join you again in a moment. Welcome back again to the second part of this episode, which is the scientific part. And Dr. Shiko Matenge is going to present us with her case, which is an interesting case. Please, Dr. Shiko.
My presentation is about a patient that means a lot to me, and I've called my presentation A Story from Africa, because this is a case that represents what goes on in many clinics in my part of the world every day. And I think there are some lessons that we can learn from this case, but also areas of cooperation and collaboration that we can get from this case. My patient is a 30-year-old male, and he has given me permission to present this case and even to show his images. Francois works for the Special Forces in Rwanda, and he developed blurring of vision while on a peacekeeping mission in another African country. He then gets treated by the mission nurse with eye drops, and when he doesn't improve, he's sent back to Rwanda to a large public hospital, where again they treat him. He reports that they treat him with oral tablets and topical medications. When he doesn't improve, he's then sent to me I work in a large private hospital in Kigali. In the hospital, he doesn't see me first. He sees another doctor who's a general ophthalmologist, this note on the left is the note in the file, and he diagnoses him as bilateral exudative retinal detachment with subretinal fibrosis. And he then continues him on steroids, but books him to see me in the retina clinic. However, Francois is busy because of the way the military works, and he doesn't wait and goes, and we actually don't see him again until July. I see him in July in the retina clinic, and I find that he has bilateral giant retinal tears very near the aura with macula of retinal detachment, with a lot of folds and already a lot of subretinal fibrosis. His vision at that time is 5/16 in the right eye and 4/16 in the left eye. And I advise him to have immediate retinal surgery. However, I do not have an in-house retinal surgeon. And the way the private hospital works is that once I gather enough cases for surgery, we summon a surgeon who comes from India and then does a list. Francois was lucky at this visit because the doctor was due to come in 3 days. And sure enough, 3 days later, he has his surgery. The doctor plans to do a phaco, PPV, a buccal, membrane peeling, fluid exchange, endo laser, cryo, silicone oil, under local anesthesia. I discussed with the surgeon and convinced him not to do the phaco because, Francois has clear lenses. However, most of the surgeons who do come here like to remove the lens before they do the retina surgery. But I felt this was a young man and I persuaded him not to do the phaco. So he undergoes surgery in the left eye. And this is this little sketch that the surgeon made. I think that according to him, the surgery went very well. We continue following up Francois. He really has a very stormy post-op period with recurrent hyphema, ocular hypertension. He has subretinal PFCL. He has subconjunctival silicone oil. It's really hard for me. Remember, by this time, the VR surgeon is gone back. It's really hard for me to manage him. He gets pupillary block glaucoma, but I keep managing every symptom. And by September, which is 2 months after surgery, his right eye, the detachment has become worse. His vision is 5/60. His left eye, the operated eye, continues having poor vision. It's a painful eye. There's evidence of PVR, and Francois is not happy at all. I then tell him that it is necessary for him to have surgery in his right eye because the detachment is just getting bigger and bigger. And he is very reluctant. He tells me that I believed you for the left eye, and the eye is worse than when I came to you. And I am about to get married. If I have the same outcome in my right eye, how will I manage my wedding? And I cannot cancel my wedding. And I really sympathize with him, and I agree. I agree that he should go get married first and then come back, because at this stage, I really cannot figure out what went wrong with the left eye. So Francois gets married in December. You can see his wife doesn't look so happy because at this time, she's kind of realized this man doesn't see very well, and he has these dark glasses that he wears all the time. And, I've never seen a bride who doesn't smile at all at the wedding, but this was really the situation in Francois' wedding. And I thank him for allowing me to share those photos. I see him again in March. And at this time, there is clear evidence of advancing PVR in the left eye. The macula is very atrophic. The eye is pre-thusical. His vision has now moved from hand movements to 1/60. The eye now has exotropia, it has hypertropia. It just doesn't look good at all. And I forgot to mention that the doctor actually did remove his lens. So he's also pseudophakic and the lens doesn't sit well. But I'm really worried about his right eye, which is now his good eye. The vision is now 4/60. The retinal detachment is continuing. I can see there's more subretinal fluid and fibrosis. And by this time, the vision is so poor that his employer asks him to stop work. Francois is very depressed. I then again try to persuade him for surgery. And this time he says, I think I should have surgery because I can see I'm going blind and I'm not functional now. However, could you please delay surgery because my wife is now pregnant. And I'm really worried that I may lose vision in this eye. And I want to see my daughter. Could you allow me to wait till my daughter is born? So at least I see her face. And if the worst comes to the worst and I go blind like the other eye, at least I will remember her face. I'm really touched by this. And because I really cannot guarantee him a good outcome in this eye, it's now more than a year since the hole developed, I think it's fair to allow him to see his baby. So we wait for the baby to be born. And we plan that we will have surgery in April and I would send him to India. However, Corona hits and Rwanda becomes the first country to impose a total lockdown. And it's a total lockdown starting on the 20th of March, 2 days after I see Francois. And this lockdown continues for a long time. And there is just total inhibition of movement. And I don't see Francois until November. And he comes to me really depressed and he says, I'm going blind. I can hardly see. At this time, India is having the worst COVID epidemic ever, and India is no longer an option. And I'm really touched by Francois's story. His other eye is really shrunken. He's in his dark glasses and he just looks like he's lost all hope. I then remember my colleagues from Egypt who I've met at various conferences and who have provoked in many of our retina sessions in our regional congress. And I sent an email to one of them and I say, I have this patient, this is the story, can you help? Because fortunately, flights between Rwanda and Egypt are still ongoing. And within hours, I get a reply from Professor Soliman and he says, send him, I will help him. The military is very cooperative and they arrange for Francois to go to Egypt and he has his surgery there. His surgery is done in May 2021 and Professor Soliman chooses to do a combination of a buccal, a PPV and a membrane peel, and you can see that there's lots of subretinal fluids, retinal bands. It's not an easy surgery, but he does it really like an expert. I was really impressed when I saw the videos because every complication that could happen could have happened. He takes his time, and finally the retina will be flattened using PFCL and then a silicone oil exchange. He doesn't have to do a retinectomy, which really impressed me. And you know, after a 360 degrees endolaser, he manages to get the retina flat. So I'll just push this to the end. Fluid exchange, and yeah, very successful surgery. This is Francois in February this year. His vision in the operated eye is now 636. He has near vision of N8, which I really don't know where it's coming from because his macula was off for more than a year. His left eye has stabilized at 260 vision. He's with almost no near vision, with lots of PVR. But he's very happy that while in Egypt, they also did strabismus surgery in that eye to correct the exotropia and the hypertropia. So cosmetically, it looks much better. I've been following him up since his surgery, and the right eye is absolutely stable. He's back to work. He just changed. His wife smiles now. His baby turned 1 year. And this is a story that really filled me with a lot of happiness. The reason I tell this story is it demonstrates things that are important for us. delay in presentation for retina cases is something we see all the time. It's very rare to see a fresh RD in my part of the world. So I believe we need to spend a lot of time raising awareness around retinal conditions. There's a lot of misdiagnosis based on poor training, because our seniors didn't get exposed to a lot of retina, but because of lack of also the correct equipment to expose us to good retina practice. Because we have a lack of ophthalmologists, there's obviously a lack of VR surgeons. And we then rely on visiting surgeons, and we honestly don't know these surgeons. We are relying on the goodwill of whoever agrees to come, and we end up getting very unreliable results, and we are left to manage those patients. But this is also a story of hope. It's a story that there is potential for intra-Africa collaborations, as we did for Francois, and that these stories can have a happy ending. But I think also there is an opportunity for us to support each other in uplifting retina standards in Africa, whether it is by joint training, joint webinars, sharing materials, inviting each other to conferences, or just through friendship like I have with Professor Soliman. So that's my story about Francois today, and I hope that through it, you get a flavor of what retina practice in Africa is like. Thank you very much.
Well, thank you very much, Shiko, for presenting this interesting case, which is in the human part of it, that we believe that a simple operation, which we consider a simple operation, can change the life of our patients. Which poses an important question. How can we actually upgrade the service, the ophthalmology service in Africa? Because what I consider is a straightforward operation is something which is considered as a miracle, which is not actually a miracle. It's just a straightforward operation. So we really have to work on it. I don't know what we can do. I think collaboration, as you mentioned, is an important aspect and an important issue, which we really have to work on, so that there's a collaboration between us, and we spend more time and spend more efforts on the development, training of our doctors. But from your side, Shiko, so what can we do?
I think we are not used to looking within the continent. So we have a lot of patients who leave Africa to go for treatment elsewhere because it's not available in their countries. And it's very rare that they look within Africa. And yet for Francois, one of the things he said to me was, it was easy for the military to support his surgery because being within Africa, they felt it was more affordable. And at that time, anyway, they were not, it was easy to go to Egypt and not to go outside the continent. But probably if not for COVID, I wouldn't have thought of sending this patient to you, and yet I know you very well. And we need to think about each other more. We need to have more collaboration between the countries along the Mediterranean and the rest of Africa. I think the fact that you attend our Congress has opened your eyes to where we are coming from, but it's also exposed us to you and your skills. And you say this is a simple operation, but I know it was not, because the surgeon who did the other eye was not a bad surgeon. So it's just because you are an excellent surgeon, that's why we got the results that we did. So yeah, this kind of collaboration, getting to know each other, attending each other's meetings, because if we don't meet, we won't know each other. So I know a good retina surgeon in Egypt. I don't know who is a good strabismus surgeon in Egypt. I don't know who's a good cornea surgeon in Egypt. So I think meeting and getting to know each other, sharing knowledge. So if you are running a seminar in your university for students, why shouldn't my students attend? They will hear about vitrectomy better from you than from me, who has to read it in a book. So I think those kind of collaborations can help.
Well, thank you very much, Dr. Shiko, for the lovely interview and the insight into the problems you meet. And as I just mentioned, I mean, this episode is not only about the retina, and it's about communication and about learning from each other and understanding the wisdom of life. Thank you very much, Dr. Shiko.
Thank you so much. Thank you so much for including me tonight. It's a pleasure.